Oral manifestations of systemic diseases. So this lecture is devoted to clinical oral manifestations of gastrointestinal diseases, cardiovascular disorders, endocrine diseases. So the oral cavity is a mirror that reflects many of the human body's internal secrets. Some of these manifestations are specific for a certain disease. Thus, it is very important to recognize them and provide correct diagnosis. Oral symptoms are not enough to provide a definitive diagnosis on their own. But for sure, they can be a significant factor in pointing a clinician toward a positive diagnosis and prompt them to investigate for the possible source of distress. In some cases, oral signs may appear in the absence of obvious abnormalities, and they can be the first symptom of diseases. Careful examination of the oral cavity may reveal findings indicative of an underlying systemic condition and to allow for early diagnosis and treatment. Examination should include evaluation for mucosal changes, periodontal inflammation, and bleeding, and of course, general condition of the teeth. Gastrointestinal diseases and their oral manifestations. Though the mouth is the entry to the gastrointestinal tract, few gastrointestinal diseases directly affect the oral cavity. For example, gastroesophageal reflux disease can be manifested in oral cavity with dental erosions, water brush, cyste, and xerostomia, burning sensations, palatal erythema, and halitosis. Such eating disorders as bulimia and anorexia could manifest with xerostomia, dental erosions, sialoadenosis, and dental caries. That's why thorough collection of anamnesis is important to outline the reason for certain clinical manifestation. Gastrointestinal disorders, reflux disease. Okay, so chronic vomiting of gastric acid contents due to such causes as hypertrophic pyloric stenosis can lead to erosion of the palatal aspect of the anterior teeth particularly. This type of dental erosion is an important diagnostic sign of self-induced vomiting in bulimia patients. So palatal aspect of the teeth that is subjected to the erosion. The oral manifestations of anorexia and bulimia nervosa include dental erosion, traumatized oral mucosal membranes and pharynx, dry mouth, dental caries, periodontal pathology, and soft tissue lesions. Self-induced vomiting may cause trauma to the soft palate and pharynx. Soft tissue lesions such as angular cheilitis, candidiasis, glossitis, and oral mucosal ulceration may also occur stemming from nutritional deficiencies. Crohn's disease. It is a chronic condition that is characterized by severe inflammation of the gastrointestinal tract. Swelled up oral mucosa which may have the appearance of cobblestone, along with inflammation of gingiva, are the pathognomic oral manifestations of the Crohn's disease. Pathognomic means specific for this disease. So symptom that is specific for this disease only. That is pathognomic. So cobblestone appearance of the buccal mucosa in patients with Crohn's disease. Another symptom, lip swelling with vertical fissure that can be deep enough. Usually they are located in the buccal sulci with hyperplastic folds and midline lip fissuring. They also can present middle fissures. There is no direct time correlation between intestinal and oral lesions. Oral lesions have been documented to precede the intestinal lesions by years. Pay attention to this statement, that oral lesions are the first. And in some cases is the only manifestation of the disease, Crohn's disease. On this photo, you can see spongy hyperemic gum mucosa in the case of Crohn's disease and angular cheilitis in the patient. Clinically, these patients present with diffuse swelling of one or both lips with associated angular cheilitis, hyperplastic rigid mucosa, and cobblestoning of the buccal mucosa. Ulcerative colitis. So such disease has been associated with destructive oral ulcerations resulting from immune-mediated vasculitis. These are similar to aphthous ulcers, but appear less frequently than lesions of Crohn's disease. There are many similarities between the oral manifestations of Crohn's disease and ulcerative colitis. Although oral lesions are more common in Crohn's disease, almost all of the so-called nonspecific oral lesions described in Crohn's disease can also occur in ulcerative colitis. Among these lesions, Piostomatitis vegetans. It occurs more commonly in ulcerative colitis than in Crohn's disease. Piostomatitis vegetans. Here you have this symptom, pathognomic symptom for ulcerative colitis. So it is a chronic mucocutaneous ulcerative disorder consisting of multiple miliary white or yellow pustules with an erythematous and edematous mucosal base. Pustules may rupture and combine together, forming snail track ulcers. Celiac disease. So it is a chronic autoimmune disorder of the small intestine triggered by the ingestion of gluten. It appears in genetically predisposed patients. The main oral signs are angular cheilitis, glossitis, depapulated tongue, and dry mouth. Ulcers are the most common type of oral lesions presenting in a papular or erosive form, generally with an erythematous margin. And enamel hypoplasia of these patients is over here. And edematous margin of gums, papular and erosive type of gingival lesions. Enamel hypoplasia is the most common manifestation in untreated celiac children and adolescents. Incisors and permanent molars are the most affected teeth, perhaps because the odontogenesis phase coincides with the active phase of the disease. Chronic atrophic gastritis. So atrophic glossitis and atrophic gastritis. So gastritis is associated with hypochlorhydria or in some cases achlorhydria. The resultant absence of intrinsic factor leads to pernicious anemia because of failure of cobalamin absorption in the terminal ileum. Acute infection with Helicobacter pylori produces a decrease in gastric acid secretion. And I'm highlighting actually this statement. Reduction in gastric acid output have an increased risk for development of gastric cancer. And the main symptom of atrophic gastritis is atrophic glossitis. So it is mucosal atrophy that appears as smooth, bald areas without lingual papilla on the dorsal tongue or may have patchy areas of erythema. Patchy areas of erythema and smooth, bald areas without papilla, the papillation of tongue. What are the symptoms of atrophic glossitis? They are pain or tenderness in the tongue, swelling of the tongue, change in the color of the tongue, discomfort to speak, eat or swallow, depapillation of tongue. So gastritis and peptic ulcer. So in general definition to gastritis, that is the group of conditions with one thing in common, inflammation of the lining of the stomach. So different type of gastritis. General symptoms that we can find out during communication with the patient. Nausea, vomiting, burning, ache, gastric reflux. And that's what the dentist could see in the oral cavity. Dental sensitivity due to erosion of enamel by gastric acid, atrophy of tongue papilla, and mucosal atrophy. Treatment, dental management. The first, to manage main disease, main symptoms, together with Dr. Gastroenterologist. And if it goes about oral symptoms, just antiseptic mouthwashes to make comfortable swallowing, articulation, communication, and applying of some vitamins A, E for of better epithelialization and formation of epithelial and healing of some ulcers or wounds that are possible present in the oral cavity due to such gastritis. Peptic ulcer, it is open sores that develop on the inside lining of stomach and upper portion of the small intestine. General symptoms: burning stomach pain, feeling of fullness, bloating or belching, nausea, heartburn, intolerance to fatty foods. Oral signs: dark erythematous tongue with a slimy yellowish coating, congestion and dilatation of sublingual veins, erosion of enamel by gastric acid, atrophy of oral mucosa. Management is such: first of all, to do treatment for the general disease, for the peptic ulcer, together with gastroenterologist, and symptomatic treatment of these symptoms. At first, prescribing of antiseptic mouthwashes. Gastrointestinal disorders could have their oral symptoms in the form of chronic recurrent aphthous stomatitis. When I say gastrointestinal disorders, I mean all parts of gastrointestinal tract, both stomach and liver, whole bile, so everything that includes in the gastrointestinal tract. chronic diseases of gastrointestinal tract will manifest in oral cavity with a chronic recurrent aphthostomatitis in majority. So after, as main element of lesion, will be present in different places of oral mucosa, in different places of oral cavity. But in a certain patient, this after has their favorite localization. It can be for one patient on a tongue, for another patient on a labial mucosa. So they have their favorite places to develop in a certain patient. So chronic recurrent aphthostomatitis were previously known as dyspeptic ulcers, but are only rarely associated with gastrointestinal disease. But it was previously. Right now we have clear understanding that chronic recurrent aphthostomatitis has in anamnesis gastrointestinal disorders. Any association is usually because of deficiency, particularly of vitamin B12 or folate acid, secondary to malabsorption. An association with celiac disease, sometimes asymptomatic, has been found in approximately 5% of patients with after. But a secondary hematinic deficiency, particularly folate deficiency, is probably the cause. The typical course of chronic recurrent aphthostomatitis is characteristic for patients with chronic colitis and gastritis. Typical course. But patients with peptic ulcer disease or chronic hepatitis, that is specific ulcerative form of chronic recurrent aphthostomatitis. In those patients who have peptic ulcer or chronic hepatitis, in this group of patients, a specific ulcerative form of chronic recurrent aphthostomatitis, Sutton's after, often develops. And actually it is Sutton's after. In this case, after turns into an ulcer with a pronounced inflammatory infiltration. On the periphery, this ulcer becomes sharply painful, has a long course up to 2 months or more, and often recurs with short remissions, no more than 2-3 months. Sometimes this lesion begins with a small spot of destruction of the epithelium that transforms into ulcer. Healing occurs with the formation of a rough scar. So Sutton after is aggressive type of aggressive manifestation of chronic recurrent aphthostomatitis. Dental management of any ulcerations. And actually the treatment is symptomatic because the reason is general somatic pathology that the treatment should be done by a special medical care provider. Dentists only do symptomatic treatment. The first point, to provide antiseptic mouthwashes, to do topical anesthesia if these lesions are painful, debridement of wound with proteolytic enzymes, anti-inflammatory and antibacterial medicaments, application, artificial lysozyme is used to improve local immune system, stimulation of reparative processes, keratoplastics to stimulate reparative processes. All these means is used for treatment of ulcerations in oral cavity. And here we have such examples of medicaments. If it is antiseptics, it can be Perio-8. Я не можу в лекції. Ну, кажи. topical anesthesia, lidocaine in spray or in gel, benzocaine, proteolytic enzymes for debridement, artificial lysozyme to improve local immune system, example such medicament Lizobact, ointments for stimulation of reparative processes, for example methyl uracil ointment, antibacterial medicaments that has antibiotics, Metrogyl, metronidazole, medicament Metrogyl Denta. It has antibiotic metronidazole in its composition. In the case of ulcerative necrotizing gingivitis. Keratoplastics, for example, oiled form of vitamin A or such combined combination of different oils, carotolin. It has in its composition rose hip oil plus sea buckthorn oil. Few oils here are combined in this medicament carotolin. Sulcoceril ointment as well belongs to this group of medicament that is responsible for stimulation of reparative processes. And clotrimazole and hydrocortisone components in such creme gel Canesten. Nie Марcia, тут не будеш дивитися. Слухай лекцію. Jaundice.
На своїй кухні плюс.
Я не можу, іди. Окей. So, oral manifestation of jaundice. Jaundice is characterized by excess of bilirubin in plasma and its accumulation within the tissues, resulting in a uniform, diffuse yellowish color of the skin, mucosa, and the sclera of the eye. The intensity of the yellow coloration varies with the bilirubin serum level. The conjunctiva of the eye are one of the first tissues to change color as bilirubin levels rise in jaundice, as they have affinity for bilirubin due to their high elastin content. This is sometimes referred to as scleral icterus. In the oral mucosa, the discoloration is more frequently found at the junction between hard and soft palate, ventral surface of the tongue, and cheeks, due to the affinity of the elastic cardiovascular diseases. The classical risk factors for cardiovascular disease are hypertension, hypercholesteremia, and cigarette smoking. Cardiovascular diseases, and the most frequent disorder of this is hypertension. So an elevated arterial pressure, it is hypertension. It is probably the most important public health problem in developed countries, and it is common, asymptomatic, readily detectable, and easily treatable. And if untreated, often leads to complications. Dentists have a unique opportunity to detect cases of hypertension. It is a professional responsibility of a dental clinician to inform the patient of their hypertensive state and to offer medical advice, including appropriate referrals. There are no recognized oral manifestations of hypertension. but antihypertensive drugs can often cause side effects, such as xerostomia, gingival overgrowth, salivary gland swelling, or pain. Lichenoid drug reactions, erythema multiforme, taste sense alteration, and paresthesia. All of that are symptoms of side effects of antihypertensive drugs. On this slide, you can see the medicaments that are used for management of hypertension and what side effect they cause. Diuretics, they cause oral dryness. Adrenergic inhibitors, they cause oral dryness plus ulcerations. Calcium antagonists, they give rise to gingival overgrowth. Angiotensin-converting enzyme inhibitors, they cause loss of taste and lichenoid reactions of the oral mucosa. Here is on this slide is collected the most typical oral manifestations in cardiovascular disease. So they are periodontal disease, lichenoid stomatitis, xerostomia, gingival hyperplasia, hemorrhagic complication, and erythema multiforme. And we start from periodontal disease. So two biological mechanisms that explain the relationship between cardiovascular disease and periodontal disease is obvious. Bacteria from periodontal disease may enter the circulation and contribute directly to the atheromatous or thrombotic process. And systemic factors alter the immune inflammatory process involved in both periodontal and cardiovascular diseases. It is known fact that there is association between hypertension and gingival periodontal pathology, but the finding failed to assess who is the first, periodontal disease and cardiovascular pathology in a result, or cardiovascular pathology as initiating factor and periodontal disease as a result of it. So this still is not obvious, but mechanism that there is a connection is clear. And here you have this such data that cardiovascular patients with active periodontal disease are 1.5, 2.7 more likely to experience a fatal cardiovascular event due to increased inflammation and increased bacteremia risk. Another manifestation, that is lichenoid stomatitis, manifestation of cardiovascular disease. Lichenoid stomatitis, here it is. Various cardiovascular drugs may induce lichenoid lesions, such as diuretics, B1 adrenergic blockers, angiotensin-converting enzyme inhibitors. What is lichenoid reaction? The term lichenoid reaction or lichenoid lesion refers to a lesion of similar or identical histopathologic and clinical appearance to lichen planus, an area which resembles lichen planus both to the naked eye and under a microscope, but another origin. Lichenoid reaction with ulceration of the dorsal tongue here you have in the 56-year-old female, secondary to the use of furosemide. And lichenoid reaction on the buccal mucosa. So another symptom, xerostomia. Different reasons can be for xerostomia, and here they are described. But in our case, we talk about xerostomia due to cardiovascular disease, due to systematic disease. So it can be sign of underlying disease or condition, but few more cases, few more reasons can be for xerostomia, including tobacco use, dehydration, nerve damage, side effect of certain medications, and that's what we are talking right now, xerostomia in a result of underlying disease. Xerostomia in cardiovascular patients can occur as well due to intake of medicaments, as in hypertension. So medicaments that are used for hypertension can lead to xerostomia. Diuretics, for example. And about xerostomia. So what is it? It is dry mouth. We all need saliva to moisten and cleanse our mouth and digest food. Saliva also prevents infection by controlling bacteria and fungi in the mouth. When the patient do not make enough saliva, their mouth gets dry and uncomfortable. Common symptoms of xerostomia include sticky, dry feeling in the mouth, frequent thirst, sores in the mouth, sores or split skin at the corners of the mouth, so-called angular cheilitis, cracked lips, a dry feeling in the throat, a burning or tingling sensation in the mouth, and especially on the tongue, dry, red, raw tongue, problems speaking or trouble tasting, chewing and swallowing, hoarseness, dry nasal passages, sore throat, bad breath. So all of that are possible symptoms of xerostomia. Gingival hyperplasia, another symptom. So gingival hyperplasia develops due to intake of certain group of medicaments. Calcium channel blockers, for example, gingival enlargement, usually apparent within 1-2 months of therapy. Tissue usually firm and painless. Overlying inflammation may occur. Here you have on these photos gingival hyperplasia. So this hyperplastic photo, 32-year-old male patient at the time of presentation shows remarkable gingival hyperplasia. The gingival tissue between teeth 11 and 12 resembled an epulis. Epulis, here as well, epulis. Extraoral examination showed excessive hairiness of the face. Desquamation was observed on the patient's back. So another presentation of cardiovascular diseases is erythema multiforme. It involves tongue and lip. It can be side effect. It can develop as a side effect of calcium channel blockers intake. Erythema multiforme. Erythema multiforme means that on this disease, the patient have different elements of lesion at the same time. They have blisters, vesicles that rupture very fast and easily. After rupture of vesicles, there is cracks. After cracking of vesicles, there is crusts. These crusts can be either with serous exudate, yellowish or bloody crusts. And erythema means that prior to vesicle there is erythema, and at the same time in oral cavity can be these three elements together immediately. So in one area there is erythema, in another area there is vesicles that cannot be detected only clinically. They have very short period of life and crack very fast, leaving after themselves crusts, bloody crusts, serous crusts. So that is erythema multiforme. And bleeding, hematoma formation. So in the case of anticoagulant therapy, if there is a problems with blood clotting, the patient takes some medicaments, anticoagulant and antiplatelet therapy they take. To such patients, minor trauma to the oral mucosa may cause various hemorrhagic lesions, including petechia, purpura, ecchymosis, hemorrhagic bulla, and hematoma formation. Petechia and ecchymosis is here on this photo. Purpura, hemorrhagic bulla in the retromolar area. One more presentation, oral manifestation of cardiovascular disease. It is trophic ulcers. Trophic ulcers. So they have their special localization. They can be localized in that areas where they where there are some proteses or some or not appropriately positioned tools that can damage buccal mucosa or tongue with underlying cardiovascular disease, such disorders with teeth could lead to trophic ulcer. They have another name, pressure ulcer, or decubital ulcer as well. By the way, it is very hard to differentiate trophic ulcer, decubital ulcer. Possibly when it goes about communication and find out systemic disease, or usually they develops in old patients. But when I look for this trophic ulcer in internet yesterday, it was very challenging to find information about trophic ulcer in oral cavity. Usually Google proposed to me trophic ulcer in any other area of body for those who have cardiovascular disease. It can be legs, back, but not oral cavity. But still, we have such table that I designed, like take from Danilevsky. I just took it and translate. So such different ulcers: decubital, trophic, tuberculous, syphilitic, and cancerous. And from this we can find out the information about trophic ulcer. So localization: mouth floor, retromolar space, and tongue. Number of elements can be single, it can be big and deep. And edges, regular. But I have here another information. Unfortunately, I did not translate from a Ukrainian book, but I can translate right now. It will be translation. Trophic ulcers usually localized in retromolar areas and on the oral mucosa of cheeks, on the tongue as well, and on the mucosa of alveolar ridge. But places can be different. Size: 0.2, 0.5 centimeters and more. They are covered with fibrinous coating. The smell of this coating is offensive, bad. They are extremely painful during touch and during food intake. The typical key point about this trophic ulcers: there is no inflammation in surrounded tissues, just ulcer presence without inflammation in neighboring tissues. Here it is even written that due to necrotic degradation, degradation of these ulcers, necrotic degradation of them, there is a possibility of profuse bleeding. If there is increase of cardiovascular insufficiency, such type of trophic after could transform in ulcers. And these ulcers, because they can be in different areas of oral cavity, in different parts of it, but if there is increasing exacerbation of disease, single ulcers can combine together, creating big one painful ulceration area. Okay, that's all about trophic ulcers. And we proceed with endocrine system. Endocrine pathology is numerous. It includes oral manifestations of diabetes mellitus, thyrotoxicosis, hypothyroidism, Cushing syndrome, Addison disease, acromegaly, hyperandrogenism, hypopituitarism, primary hyperparathyroidism, and a lot of. On this lecture, I focused on diabetes mellitus manifestation. So diabetes mellitus is one of the most common systemic chronic conditions that the dentist will face in a busy dental practice. Diabetes mellitus is a chronic metabolic disease that is characterized by hyperglycemia due to either a deficiency of insulin secretion or resistance to the action of insulin or both. Chronic hyperglycemia leads to different complications in various regions of the body, including the oral cavity. So blood glucose control is very critical. Type 1 diabetes is usually diagnosed in childhood. Many patients are diagnosed when they are older than age 20. In this disease, the body makes little or no insulin. Daily injections of insulin are needed. The exact cause is unknown. Genetics, viruses, and autoimmune problems may play a role. Type 2 diabetes is far more common than type 1. It makes up most of diabetes cases. It usually occurs in adulthood, but young people are increasingly being diagnosed with this disease. The pancreas does not make enough insulin to keep blood glucose levels normal, often because the body does not respond well to insulin. Many people with type 2 diabetes do not know they have it. Also, it is a serious condition. Type 2 diabetes is becoming more common due to increasing obesity and failure to exercise. So symptoms of type 1 diabetes: fatigue, increased thirst, increased urination, nausea, vomiting, weight loss, in spite of increased appetite. Symptoms of type 2 diabetes: blurred vision, fatigue, increased appetite, increased thirst, increased urination. Oral manifestations: dental caries, candidiasis, xerostomia, burning mouth syndrome, periodontal disease, and oral mucosal lesions. So dental caries. There is not a clear and direct association between type 2 diabetes and dental caries. However, it is well known that diabetes is associated with dry mouth and a decrease in salivary secretion, and it is a clear risk factor for the development of dental caries. And here I put this diagram, saliva, that plays a main role, not main role, but one of important roles in maintaining the health of oral cavity, as it provides buffering to acids that is produced by microorganisms. And as well, saliva in appropriate quantity do mouth washing and helps in articulating and food swallowing. So presence of saliva is important. Moreover, saliva as well, as I said, neutralizes byproducts of microorganisms. And actually these byproducts, lactic acid, maleic acid, all of that destroys enamel, leading to cavity. So if there is a lack of saliva, there will be caries. And in the case of diabetes mellitus, due to microangiopathy, salivary glands actinus is destroyed. That's why salivary glands cannot produce saliva at all, or they produce it in small quantity or with a bad quality. So in any case, there is xerostomia. Periodontitis. So periodontitis is one of the problems that diabetes mellitus patients can face. Periodontitis, it is chronic inflammation that results in a progressive destruction of the supporting tissues of the teeth, as well as pocket formation, recession, or both, which may lead to tooth loss due to damage of the alveolar bone. Okay, so on these photos, you can see clinically periodontal abscesses, inflammation of gums. So pocketing, gum recession, accumulation of plaque, calculus, all possible symptoms of periodontal pathology. So people with diabetes are at high risk for oral health problems such as gingivitis in the early stage of gum disease and periodontitis. People with diabetes are at increased risks for serious gum diseases because they are generally more susceptible to bacterial infection. They have a decreased ability to fight bacteria that invade the gums. And photos represents gingivitis in a patient with uncontrolled diabetes mellitus. Hyperemia, swelling, abscessing, pocketing, suppuration possibly, all of that is present in this case. The oral tissues most commonly affected by diabetes are the periodontal tissues. These can appear as redness, swelling of the gingiva, bleeding from the gingiva with minor provocation, looseness and spacing of teeth, and exposed root surfaces at risk for caries that may or may not carry plaque and mineralized deposits. Oral lesions of diabetes are such. In addition to periodontitis and dental caries, other oral conditions commonly occur in patients with diabetes. These include fungal infections, salivary gland dysfunction, neuropathy, and mucosal disorders. These disorders are related to chronic salivary hypofunction and to the generalized immune dysfunction seen in diabetic patients. And xerostomia is reported to occur in 40–80% of diabetic patients and is related to decreased salivary flow rates. The oral mucosa is normally protected by saliva when it is adequate in amount and quality. Saliva provides lubrication, cleansing, pH buffering, antimicrobial proteins such as secretory immunoglobulin A and aggregation, and clearance of bacteria. The epithelium and minor salivary glands in the mucosa contribute to innate immunity via alpha and beta defensins, histatin, and other antimicrobial peptides. The mechanism by which salivary flow is affected in diabetic patients is thought to be the result of autonomic nerve dysfunction or microvascular changes that diminish the ability of salivary glands to respond to neural or hormonal stimulation. So that is the mechanism why xerostomia develops in diabetic patients. On this photo, you can observe the patient with type 2 diabetes mellitus. On the photo A, salivary gland hypofunction and periodontal disease in a patient with type 2 diabetes mellitus. Burning mouth syndrome, another manifestation. So first of all, what is burning mouth syndrome? It is a burning sensation in the mouth with no underlying known dental or medical pathology, usually due to stress. That is primary. A burning sensation of the oral soft tissues is a frequent complaint in diabetic patients, making diabetes a systemic condition most frequently associated with this symptom. Although oral mucosal conditions such as candida infections, lichen planus, and dryness can cause burning sensation in diabetic patients. A neuropathic basis is supported by observation that the burning sensation in diabetic patients are frequently accompanied by changes in taste, dysgeusia, or other sensory distortions. Additionally, patients with peripheral diabetic neuropathy are more likely to have burning sensations in oral tissues than those without peripheral neuropathy. In a case of systemic disease, we talk about secondary burning mouth syndrome. Tongue abnormalities. After periodontal tissues, the oral site most frequently affected in diabetes is the mucosa of the tongue. The fissuring may be the result of a chronic low salivary flow rate, which alters the environment in the oral cavity such that slow healings of tissues. And as a result, such an attractive and painful condition can develop as a bald tongue. Bald tongue, it is atrophy of the tongue papilla that results in such appearance, bald tongue. As well, angular cheilitis can be present due to xerostomia. And it is redness of fissures at the corners of the mouth involving the junction of the mucosa and skin, and may also represent a form of candidiasis. So everything comes from xerostomia. So all mucosal problems is in a result of xerostomia. Another condition in diabetic patients that can be observed, it is median rhomboid glossitis. So this condition features focal atrophy So as median rhomboid glossitis, yes, I stop on this. So a unique condition in which an atrophic bald spot is located in the midline, posterior surface of the tongue, anterior to the V-shaped circumvallate papilla, and it is called medium rhomboid glossitis. It is commonly smooth and flat, but may be depressed or have a lobular to papillary surface. Another condition, benign migratory glossitis. This condition features focal atrophy of the papilla of the tongue in an irregular geographic pattern with characteristic prominent white or yellowish raised borders that migrate over time. And this condition is not caused by a candida infection, but is characterized as inflammation. It may also be associated with similar symptoms of pain, itching and burning of the mucosa. Oral candidiasis, another symptom in diabetic patients. So low salivary flow rates are significant because saliva provides a protective coating for the oral mucosa that contains antimicrobial proteins and immunoglobulins, buffers acidic foods and liquids, and contains calcium, which is important for mineral exchange at the tooth surface. Lack of adequate saliva leads rate and difficulty with maintaining oral hygiene, as well as a decrease in quality of life because of discomfort from eating, swallowing, and talking. Opportunistic fungal infection. They are commonly associated with diabetic patients and hyperglycemia. Salivary dysfunction compromise immune function of oral cavity. And due to this, such opportunistic infection progress. Salivary hyperglycemia provides substrate for fungal growth. Lesion planus. So white areas of the mucosa that do not wipe off may be a sign of condition known as lesion planus. It is a chronic subepithelial inflammatory disorder that results in a characteristic lacy or patch-like white pattern over reddened mucosa. Whittem network or Whittem stria. So these are as well can be one of the symptoms in diabetic patients. However, similar mucosal changes called lichenoid drug reactions occur as an adverse side effect to medications that diabetic patients are commonly prescribed. So lesion planus as adverse effect to medications. Lesion planus or lichenoid reactions may be symptomatic with pain, burning sensation, and sensitivity to acidic foods. Another endocrine diseases such as hypoparathyroidism can be accompanied with upper lip twitching. Hyperparathyroidism is accompanied with TRR affection and brown tumors on the skin or on the gingiva. Gigantism acromegaly is manifested with spastis, mandibular prognatism, macroglossia, and megadontia. Cushing syndrome has such signs: fatty tissue deposition, moon face, osteoporosis, pathological fractures of the mandible, maxilla or alveolar bone, delayed healing of fractures, and also soft tissue injuries. Addison's disease has such oral signs: bronzing, hyperpigmentation of the skin, oral mucosal melanosis, buccal mucosa tank. In conclusion, it is worth to say that very often oral manifestation would be the most preliminary sign of a systemic pathology. Numerous systemic pathologies may point to common oral manifestations, or any specific oral manifestation may be associated with a particular disease. An accurate and timely diagnosis by the dentist can assist the patient in identifying the underlying pathology. Hence, a dentist must be well equipped, both clinically and academically, to be able to diagnose the pathology. Okay, that is the end of this lecture. Thank you.
Thank you, Professor.
You as well. I suggest to start another lecture in 20 minutes, 12:30.
Okay.
Okay. You can do stop recording, or I don't know how you did this, or you record everything.
Yeah, Professor, I'm trying to stop it now.